Welcome and thank you for joining. My name is Solange Patarroyo. I'm Health Educator for Community Health at Atlantic Health System. Today, webinar Colorectal Cancer, what is, how do we treat, and how can we prevent, is presented by Dr. Joseph Flanagan, colorectal surgery at MNC. He's part of the Atlantic Health System group. Before we begin, I have a few announcements. All participants are muted. Please use the Q&A button for questions or the chat or button for comments.
Good afternoon, everyone. My name is Joe Flanagan. I am a colorectal surgeon with Atlantic Medical Group. Thank you so much for joining us on this Friday afternoon. And thank you to Sol for helping to organize this. So today we're going to be talking about colon cancer, something that I'm very passionate about. And the objectives are to define what colon cancer is, to become aware of colon cancer symptoms, to explore how colon cancer is diagnosed, to discuss the treatment options available for colon cancer, and to identify ways in which colon cancer can be prevented. I have no disclosures other than I'm very passionate about this topic. And quick background about myself. I grew up in northern New Jersey in South Orange. I went to Del Barton for high school, which is a school in Morristown. I went to Georgetown for undergraduate in Washington, D.C., and then I came back to New Jersey for medical school at Rutgers. And I did my residency at Morristown Medical Center. I did a one-year fellowship in colorectal surgery out in Long Island at Northwell Health. And I am fortunate enough now to be an attending colorectal surgeon back at Morristown. Through my journey, I've had amazing mentors, in particular, Dr. Rolando Rolandelli, who is the chairman of surgery at Morristown and my senior partner. Also, my other two partners, Doctors Varun Krishnan and Julia Tolentino. I'm just thrilled to be working with such a great group. And to me, I love being a colorectal surgeon. I think it's the coolest job in the world. I love everything we do, from colonoscopy to anal rectal disease, diverticulitis, inflammatory bowel disease. But colon cancer is kind of my true passion. And so while I'm passionate about all of it, I really love treating colon cancer. And I am just thrilled to be doing this outreach to the community, because the treatment of colon cancer begins in the community. And once we can inform and educate the community about colon cancer and about how to prevent it and how to diagnose it early, that's just going to lead to better and better outcomes. As much as I love to operate as a surgeon, I think an ounce of cure is worth a pound of prevention. So I want to, help to diagnose this early, and for people to not, need to see me would be the goal. So let's start by talking about what the colon is. I know that a lot of people in our audience do not have a medical background, which is fantastic. And so I just want to do a little brief anatomy lesson. Let's imagine that this represents someone who is facing us. So when surgeons say right and left, it's opposite what everyone else says, because we're discussing the patient's right and the patient's left. So in this screen here, the left side of the screen is actually the patient's right. I don't know if you can see my mouse, but this structure I'm hovering over is the liver, which tends to be on the right side of the patient. Over here would be where the spleen is, which is the left side of the patient. The esophagus is a muscular tube that brings food from the mouth through the chest and into the abdomen. The diaphragm separates the abdomen from the chest, and once it reaches the abdomen, it goes into the stomach. The stomach is a temporary storage unit that begins breaking food down, and then food enters the small intestine, of which we all have about several feet, several meters even inside of us, and it goes all over the belly and then eventually ends up in the right side of the colon. The right side of the colon has the appendix that comes off of it, and then the colon traverses up by the liver, comes across the abdomen, takes a turn at the spleen, and then comes down to the rectum. And through the rectum, the stool is excreted into the outside world. So purpose of the colon is to absorb water, is one of the primary functions of the colon, and to absorb water and to create solid stool. The colon also produces mucus to help keep the stool lubricated as it passes through. This picture is just a little bit more in detail of the colon. So the cecum is the first part of the colon, again, by the appendix. Then we have the ascending colon, the hepatic flexure, which is just a fancy way of saying the turn that it takes at the liver, transverse colon, which comes across the abdomen, and then the splenic flexure, which is the turn that the colon takes at the spleen. And why is this all so relevant? Well, colon cancer is different when it's on the right side versus the left side. The operation is very different. It's approximately 50-50, maybe a little greater than that on the right side. So maybe more like 60% on the right side, 40% on the left side. But the different parts of the colon kind of have different characteristics that guide, the operations that we do. And it also impacts the symptoms that patients present with. And we will discuss symptoms in greater detail a little later in the lecture. So this slide here is, you think of the colon as a tube. So as it's going through this, this trajectory, it's a hollow tube through which the stool passes. So this would be what we call a cross-sectional view, or a cut in the tube. The middle is called the lumen, and the lumen is where the undigested food and the stool, passes through. And the reason this is very relevant is because the tissue that interacts or interfaces with the lumen is called the mucosa. And for today's purposes, approximately 99% of colon cancer starts from the mucosa. And it's also very relevant in staging colon cancer, because the way that we do the local staging, which we refer to as the T staging, has to do with how far into the colonic wall the cancer extends. So again, to reiterate, about 99% of colon cancer emanates or starts from the mucosa. That's called adenocarcinoma. And it's also important because we need to know how far into the colon wall the cancer extends. And hopefully this will make more sense in a little bit, because I'm going to discuss kind of what cancer is on a high level. Now, as a surgeon, I wish it was as simple as this, but it's actually much more complex. So every tissue in our body requires blood supply to function. Blood supplies nutrients and, most importantly, oxygen to our tissues. And the oxygen is used by the cells in our tissues to perform the functions that they need to perform. So for example, if we're looking at these cells here, these cells need oxygen to be able to absorb the water from the lumen of the colon, and to make solid stool, and to produce mucus. All these functions that the cells carry out would not be possible without oxygen. So this major vessel you see coming down the middle here of the screen, this is called the aorta, which is the major blood vessel in the body. And it gives off two major arteries that we're concerned of. The first is the superior mesenteric artery, which supplies the right side of the colon and the transverse colon. And then the second is the inferior mesenteric artery, which supplies the descending or left side of the colon, the sigmoid colon, and the rectum. And as a colorectal surgeon, and for colon cancer, this is especially relevant because in order to adequately stage, and we'll talk about that more later, colon cancer, one needs to obtain an adequate amount of lymph nodes from the specimen that is taken out of the patient. And the lymph nodes tend to traverse or be gathered around these blood vessels. So when we do an operation, we need to make sure that we're taking a good nodal sample. So we need to make sure that we take the blood vessels that supply the side of the colon that we're taking. So for example, if we're removing the right side of the colon, we have to make sure that we take the ileocolic artery, the right colic artery, and the right branch of the middle colic artery. Not only does this ensure a good nodal staging, but it also makes sure that we leave adequate blood supply for the remainder of the colon that's left behind, so that in the absence of the colon that we take out, the rest of the colon can function normally and give the patient a good quality of life after the operation. And again, it gets more complicated because this does not look like this in person. Unfortunately, it's not a textbook, so it tends to look more like this. So this is the yellow you see here is what we refer to as the mesentery, and the lymph nodes and the blood vessels are embedded within the mesentery. So how do we define cancer? You could spend an entire college semester discussing this. People have dedicated their lives to this very question. But I want to keep it simple and say that cancer is abnormal cell growth with the potential to invade and spread to other parts of the body. So I'm just going to backtrack to this slide here. All of the organs in our body are composed of cells. We all contain trillions of cells within our body. These are the basic functional units of an organ or of a particular piece of tissue. We tend to think of DNA, and I certainly did before I went to medical school, as being passed on from generation to generation. So we all have DNA that we inherited from our parents. And this is certainly true, but each cell produces DNA that then becomes the next generation of cells. And sometimes this generational change can occur within days, weeks, months, years. But we are all constantly forming new cells and becoming new cells. It's actually kind of a trippy thought, but we are quite literally, even though we are the same people, we are comprised of completely different cells than we were 5 years ago, 6 years ago, 10 years ago, because the cells are constantly turning over. One of the reasons why the colon is particularly susceptible to forming cancer is because these cells that line the mucosa are constantly turning over. They're constantly interacting with the food that we eat. They're constantly functioning. So they're constantly being sloughed off into the lumen and getting excreted. But then also they have to produce new cells to fulfill the role that they had once fulfilled. So it's an area of high cellular turnover, and it's these areas that tend to be prone to cancer. For example, muscular cancer is not that common. We call that sarcoma, and that's because the muscle is it's more of a set tissue. It can grow when if you weight train or run, etc. It can certainly grow bigger. The cells grow bigger, but they are not constantly turning over in the same way that colon cells are. So this is kind of a very rough schematic of what happens. So we have a normal cell, and the normal cell wants to pass its DNA to a future generation of a cell, but something happens, and that DNA does not get transmitted properly to the next generation, and now we have a genetic change that isn't supposed to be there. And now this genetic change enables this cell to start replicating in an abnormal way. It tends to replicate and reproduce much faster than normal cells. And eventually, over time, that replication, that abnormal cell, becomes a malignant tumor. And again, this is what it looks like in the colon here, with where the magnifying glass is. This is depicting a left-sided or sigmoid cancer. But this is a very important concept, and it's actually, I'm going to talk about it in more detail later, but it's the reason why we do screening colonoscopy, because this normal cell to malignant tumor progression occurs over years. So the thought process is that if we can try to intercept this change somewhere early, we can prevent the full-blown progression to a colon cancer. So why is this all so important? Why am I so passionate about this? In medicine, epidemiology is the study of populations. How do disease processes affect populations? How are certain populations more susceptible to diseases than other populations? So just a little bit about colorectal cancer. Colorectal cancer is the third most common cause of cancer in the United States and globally, and it is the second most common cause of cancer death. Furthermore, it affects men and women equally, approximately 50% each. Breast cancer and prostate cancer are certainly very important disease processes, and my colleagues who treat them are amazing physicians. However, they tend to affect one biologic sex over the other, whereas colon cancer, there is no discrimination. It affects, everyone approximately equally. So it's you know, um, a very common illness. The mean age of diagnosis is 67 for men, a little later than for women. But as we can see, it's a very important disease process, and strategies to reduce its impact are going to improve and lengthen the lives of populations. So what are the symptoms of colon cancer? So anytime a patient has a change in bowel habits, this kind of raises a red flag in my mind. So if you go from, hey, I was regular every day, I had one bowel movement a day, to, now I have a bowel movement every couple of days, and the caliber is different. It's more narrow than it used to be. Well, that kind of description can be indicative of a left-sided tumor. We said earlier that depending on what side of the colon it's on, we can have different symptoms. The right side of the colon tends to be larger in caliber. So even if there is a tumor invading, stool can still get by it rather normally. And also the stool that enters the right side of the colon tends to be more liquid because it's coming right from the small bowel. And recall that one of the main purposes of the colon is to absorb water as it comes around. So as stool hits the left colon, most of the water is absorbed and it's solid stool. So now, if there is a lesion impinging in the left side of the colon, it's going to narrow the caliber of the stool. And this is why sometimes, not always, but sometimes right-sided cancers can present a little later in the progression because it's not as obvious, it's not as symptomatic. Blood in the stool is another symptom. Now, again, there are many other things that can cause blood in the stool, hemorrhoids, diverticulosis, fissures. However, in patients of an appropriate age, whenever I hear there is blood in the stool, I almost always recommend a screening colonoscopy. Unintentional weight loss is another kind of vague symptom. Someone says, I lost 20 pounds the past year. I wasn't intending on it. I feel like I've been eating normally. That is, worth investigating further. And then vague abdominal pain. And, one thing that I just want to emphasize, I don't want to swing the pendulum too far. I don't want, everyone in this webinar to be concerned if they have any of these symptoms, because oftentimes it is described by something else. And I'm going to equip you with some very good rules as to when you should get a colonoscopy, which is the gold standard in diagnosing colon cancer. So this is what a normal colonoscopy looks like. So all this is inside the colon, and I know this because I know I've done hundreds, if not thousands, of these. But this would be the transverse colon, kind of these triangular folds. But you see that all of the tissue looks relatively uniform. There's nothing that really stands out. There's no sort of red flag or alarming looking piece of tissue. All the tissue is glistening, it's healthy appearing. You can see the vasculature, it's getting good blood supply. Contrast this with a tumor. So the tumor looks radically different than the rest of the colon. So on the top of the screen here, this would all be normal colon, like the previous slide, normal glistening. But then you see this huge mass here that's just abnormal. It's not growing or behaving in the same way as the rest of the tissue. And I think this is an excellent photograph to illustrate that point, that cancer just behaves abnormally. It behaves differently. It has a mind of its own. It behaves in an uncontrolled, unregulated way. And that's why it can become so dangerous, because when it metastasizes or spreads to other parts of the body, it takes up a lot of our energy. And that's ultimately what leads to death from colon cancer. Is it'll get to the liver or to the lungs or into the bloodstream, and it will, just take all of the energy that should be going to other parts of the body to perform normal bodily functions that are compatible with life. So once we diagnose this, once that we've done a colonoscopy, and this, and one other thing to emphasize is seeing this alone is not enough to make the diagnosis. What we would do as colorectal surgeons or as gastroenterologists, who are also very skilled colonoscopists, is we would take biopsies of this lesion, and we would have our colleagues who are pathologists look at it under the microscope, and they have been trained to determine, okay, for sure, what a cancer is versus what is not a cancer. So they would look at this and they would give us the definitive diagnosis. So what do we do after colon cancer has been diagnosed? Well, now we need to start thinking about staging it. So the first step is we want to make sure there are no metastases. So we get CAT scans of the chest, abdomen, and pelvis. And what CAT scans are is it's a very high resolution, high definition scan that gives cross sections of the patient through their body. So you're looking at slices. And the major areas of concern in colon cancer are looking at the liver to make sure there are no metastases to the liver, and the lungs to make sure there are no metastases to the lungs. The pelvis is helpful, especially in left sided colon cancers, to determine the spread of the tumor locally. Is it invading surrounding structures? Is it confined to one area? Sometimes it might not even be visible on the CAT scan. So this is why we do that. We also do lab studies. Usually we want to check a blood count. We usually want to look at electrolytes, potassium, magnesium. All these things give us an overall picture of the patient's health. But then also there's something called a CEA level, which stands for carcinoembryonic antigen. And this is helpful in tracking once the cancer has been removed. Sometimes a metastasis might not be obvious, but the patient might develop an elevation in their CEA, years after a resection, and that might give us a clue that, hey, we should probably repeat a CAT scan or do another colonoscopy just to investigate this a little further. So colon cancer cannot be adequately staged. We do this stuff first before the operation, but the real way to stage it is by doing the operation. And this is from the NCCN guidelines, which is the National Comprehensive Cancer Network. And it's just a way that we're all speaking the same language. All colorectal surgeons or surgical oncologists who do this kind of surgery, and the oncologists who get involved, and the radiologists, the pathologists, just that we're all on the same page and that we're all speaking the same language. But I think for the purpose of this lecture, this gets very confusing very fast, even for me. So I'm going to simplify the staging process. So the way I look at it is stage one is local with superficial spread. And what I mean by that is that the cancer is only in that part of the colon. And if we, again, backtrack, it has not penetrated all the way through the wall here. It might just be confined to the mucosa or to the submucosa, but it hasn't gone all the way through. Stage two means locally invasive. So again, thinking of that slide, locally invasive would mean it's confined to that area of the colon, but the tumor is growing through multiple walls of the colon. And the reason this is important and this has implications is because the more it spreads into those walls, the greater the chance that it could catch into the lymphatic system and metastasize to the lymph nodes. And for example, when cancer metastasizes to the liver, usually it's a progression. It goes through the walls, then into the lymph nodes, and then to the liver. Spread to the lung is a little different. That tends to be through the bloodstream. But the local spread of the tumor is important. And that's why a stage two cancer has a different prognosis than a stage one cancer. Stage three cancer means that there are lymph nodes involved. So whenever we resect the colon or cut the colon out for colon cancer, you want to see 14 lymph nodes at least in the specimen. That indicates a good lymph node sampling. So when the lymph nodes are involved, when the cancer is in the lymph nodes, in some sense, the cat is out of the bag. It is now beyond the colon and it's into the surrounding tissues, it's into the lymph nodes, and we get more concerned. And finally, stage four is when that metastasis has occurred to another organ. And again, usually that is the liver or the lung. One very, very interesting thing about staging, and just to back out for a second, one of the things I love about being a colorectal surgeon is that at all stages, and yes, even stage four in specific circumstances, this is a very curable disease. And it's just amazingly gratifying to be able to cure patients of this disease. And one thing that's fascinating is in some cases, stage three has a better prognosis than stage two. And my thought on this is that when a patient has stage three, they almost always get chemotherapy after the operation. With stage two, the paradigm has not been to give chemotherapy, and maybe that extra protection that the patient gets from the chemotherapy really does have an impact on survival. But all survival, stage one, stage three, is well over 50%. It's an excellent prognosis with modern medicine. And to address that issue with stage two, where we are shifting now is the pathologists are looking at very specific details where, okay, this might be stage 2, but tumor cells have some concerning characteristics that concern the pathologist, that they were kind of on their way towards metastasizing to the lymph nodes or to other organs. And if those characteristics are present, we will have a conversation with our medical oncologists and we will consider giving chemotherapy. So I think we'll see over the next couple decades, or years, certainly a couple decades. I think we're going to see better prognosis across all stages. And then just one comment with stage 4: if there is an isolated liver or lung metastasis, meaning it's not encompassing the entire liver, but it's a segment of the liver that's involved or part of the lung that's involved, we can remove the affected part of the colon, and then we can have either our surgical oncology colleagues for the liver or our thoracic surgery colleagues for the lung remove that part of affected lung or liver. And in selected patients, they can have a greater than 50% 5-year survival, which is just amazing and has been an amazing development over the past several decades. So I already spoke a lot about this, but surgery is the mainstay of treatment in stages 1 through 3. If you have a diagnosis of colon cancer, in my mind, it's got to be removed. Now, again, I think this is a little beyond the scope of this lecture, but we have some brilliant and talented gastroenterology colleagues who, if we can prove that the cancer is very local and very non-aggressive, they can actually remove it in a colonoscopy setting, which is amazing because it prevents the patient from going through the morbidity or complications associated with a major operation. That being said, surgery is still the mainstay of treatment, and surgery is necessary to adequately stage the tumor, and then that guides whether or not we give chemotherapy. That's back to this slide. You can only make this staging determination after you have the specimen and after the specimen has been looked at by the pathologist. As I said earlier, for stage 3, we recommend chemotherapy. And I think one direction this is going is that certain stage 2 characteristics will necessitate postoperative chemotherapy. Stage 4, again, there are certain circumstances in which we can do a combined resection, and that's awesome and has good 5-year survival rates. However, if the entire liver is involved or much of the lungs involved, or it has gone to the brain, that in that case we do not operate. We give chemotherapy and biologic therapy. I'm going to mention biologic therapy a little later, but I think that's an exciting new direction that could also potentially provide improved survival for stage 4. So this slide here, I've spent 11 years of post-college training and education to learn how to do what's depicted on this slide. So what does the surgery look like? Let's say in this example, the tumor is in the sigmoid colon. We need to get a 5-centimeter margin on either side of the tumor. We disconnect that part of the colon with the margin from the rest of the colon, and then we hook up the colon to itself. That's called an anastomosis, and that enables the patient to still have bowel continuity, which will give the most optimal quality of life post-operatively. This is opposed to bringing an ostomy or a bag out. Patients tend to do okay with that, but it's much more optimal to bring them back together, because then you're having normal bowel function, you're having bowel movements, and you maintain the dignity and quality of life of the patient. Most of the time, within a few months of surgery, patients will be pretty much back to normal in terms of bowel function. After surgery, in the immediate weeks or months post-operatively, they might have more frequent bowel movements, but then the rest of the colon sort of compensates and starts to absorb more water than it used to, so that the stool consistency and the bowel movements are pretty much the same as preoperatively. And patients can go on and live decades after having this surgery. But again, I'm reminding you of the slides earlier. I wish it were as simple as this, but it actually is much more complex. We have to take a wedge of mesentery, because that surrounds the blood vessels. So when we get the blood vessels near their origin, meaning near where they originate, so for example, if we were doing a sigmoid cancer, we would want to take the inferior mesenteric artery here just off the takeoff from the aorta. And given the aorta is the major blood vessel in the body, this is always, for me, the most harrowing part of the case. But by doing we call it high ligation, you're ensuring an adequate lymph node harvest. So I think this is the direction that all of medicine is going, in my opinion. How do we prevent colon cancer? Because again, as much as I love to operate, I would rather patients not develop colon cancer in the first place and not need to see me. There's plenty of other things I treat, so I'll always be busy. But preventing colon cancer, I think, is really what's going to improve quality of life and prevent deaths, and from a population perspective, give us the most bang for our buck. So the gold standard in preventing and diagnosing colon cancer, bar none, in my opinion, and I think most gastroenterologists, colorectal surgeons, surgical oncologists, medical oncologists would all agree with me, is screening colonoscopy. And luckily, we have some very thoughtful guidelines as to who should be screened. So if you're an average risk, meaning you don't have a family history of colon cancer, you've had no symptoms, meaning no blood per rectum, etc., no change in bowel habits, no change in the caliber of your stool, we recommend to start screening colonoscopies at the age of 45. And that enables the colorectal surgeon or the gastroenterologist to evaluate the colon and really look to see if are there suspicious polyps, is there a tumor. Most of the time when we do this, the screen colonoscopy, it comes back normal, and that is great. It gives the patient peace of mind. We recommend that if patients have had several clean colonoscopies with no concerning findings, they can pretty reasonably stop screening colonoscopies after the age of 75. And then if they ever develop concerning symptoms, then we can go back to the drawing board and do a colonoscopy. And another very important thing is for patients who have had a family history of colon cancer. So if you have one or more first degree relatives with colon cancer or with polyps that were advanced, meaning large, or had concerning features that the pathologist tells us, the guidelines are slightly different. So in that case, we recommend age 40 or 10 years before the age of the youngest relative at the age of diagnosis. So that's wordy. What does it mean? If you have a parent who had colon cancer at age 55, 10 years before 55 would be 45. So you would get the colonoscopy at 40 because it's a first degree relative, and 40 comes before 10 years prior to the age of diagnosis. If, however, you had a parent or a sibling who developed colon cancer at the age of 45, 10 years before 45 is 35. So that's when we would recommend you start screening colonoscopy. It's conservative. We want to err on the side of screening early. Colonoscopy is a very safe procedure. It's not fun taking the prep, but it's a very safe and very effective procedure. So that's why we are on the side of screening early. So I want to remind everyone of this slide. So this slide was a very basic schematic diagram of how we go from a normal cell to a malignant tumor, but in reality, it's much more complex. So what this depicts is that there are genetic changes that happen from normal cell, genetic change, abnormal cell, genetic change, polyp, genetic change, tumor. And this process usually takes about a decade, certainly several years. So the theory with colonoscopy is if we can do a colonoscopy and we can catch things here, where it says small adenoma, that's just a small little polyp, then we take it out during that colonoscopy, well, then that stops the progression to cancer. So that's the other reason why screening colonoscopy is so powerful and so effective. It's not just that we're detecting full-blown cancer at an early age, it's that we're detecting polyps before they have progressed to cancer. And that is why colonoscopy is such a powerful tool. So this is something that I've become very passionate about over the past couple of years. In fact, my wife and I watched an amazing documentary that I highly recommend on Netflix called The Blue Zones. And it's all about populations of people that live longer than expected, that live to age 100. And there are a lot of commonalities between these communities. One was Okinawa, Japan. One was in Costa Rica. One was in the Greek Isles, and one was in Sardinia, which is an island off the coast of Italy. And basically, these people all eat whole foods. They eat foods that are not processed, and they all live active lives. And if there's one thing other than colonoscopy, if there's one thing that I could impart, it's that I believe that over half of medical problems can be, if not prevented, at least made better by a healthy lifestyle. So eating well and exercising. So what do we mean by eating well? I've been recommending the Mediterranean diet. The Mediterranean diet is a diet rich in fruits and vegetables, whole grains, and um, legumes, so beans, stuff like that, also nuts and seeds. Now, I just want to make it clear, I'm not telling people to stop eating meat. I love a great steak every now and then. I love chicken and fish, but if you're going to have that, make sure that it's minimally processed and also that the rest of your plate has a bunch of this stuff on it, the veggies, the legumes, the whole grains, the fruits. Because my theory is twofold. Number one is that these compounds, these fruits and vegetables, have anti-inflammatory compounds in them, antioxidants. And I bring up a couple slides because this is really interesting stuff. Looking at, and these are very high quality reviews at great institutions, but looking at the effect of the Mediterranean diet on the development of colon cancer. And something that's very interesting is that not only does it seem to prevent the development of colon cancer, but also when colon cancer has been diagnosed and developed, if patients adopt a Mediterranean diet, it seems to slow the progression of the cancer. And I think that's attributed to the antioxidant properties that are in tomatoes, olive oil, basically colorful fruits and vegetables. The other thing is that the Mediterranean diet has a lot of fiber in it, and fiber promotes regular bowel movements. So if you have a low fiber diet and you're constipated, the stool and the undigested food is going to have more time to interact with your colon mucosa. And then the mucosa is going to turn over more. And just by probability, the act of creating more cells, one of those cells is bound to become abnormal, is bound to become a precancer to cancer. So if we can keep our bowel movements regular and not be constipated and have a fiber and fluid rich diet, you're minimizing that interaction because things are flowing through in a more efficient way. So I think that's the second thing about the Mediterranean diet. So it's the anti-inflammatory properties, but also the fiber content. And so where do we go from here? This timing is perfect. We're right at about 12:45. I do want to save a couple minutes for questions, but I think the future of treating colon cancer is going to be biologic therapy when we treat metastatic disease. So what biologics are, usually chemotherapy just treats cells that turn over a lot, that are dividing a lot, targets the DNA. So obviously the cancer cells tend to be those types of cells, but then there's also all sorts of side effects because lots of cells in our bodies are turning over frequently. So biologic therapy says, okay, look at this mutation that this cancer has. Let's go after that molecule. Let's go after that mutation so that it can be much more targeted to the cancer cells. And then again, as I said earlier, I think it's all about prevention. How do we have more lectures like this? How do we distribute this knowledge to the general population? How do we, get people to eat better, to be more physically active? I think that's, again, an ounce of prevention is worth a pound of cure. And then finally, the microbiome. So, this might, again, be kind of trippy to some people, but we have more bacterial cells in our bodies than we have human cells. And we are just beginning to understand the interplay between these bacterial cells and us. And a lot of them are very helpful in helping us lead healthy lives, especially the bacteria that reside in our colon. When those bacteria get disrupted, like after we take an antibiotic, that's what makes us more prone to C. diff, which is bad bacteria. So how do we maybe investigate and recruit those cells that are good cells to combat cancer? I think that's another huge thing that will be more apparent and clearer within the next couple decades. Well, thank you all. This was an absolute pleasure. Thank you so much to Sol for helping organize this, and I hope everyone learned something.
No, thank you, Doctor, and thank you for joining us. And really, and a special thank you, Dr. Flanagan, for dedicating your time and expertise today. If you have additional questions or comments, send an email to communityhealth@atlantichealth.org or call us. And again, thank you.